for the Health Commission Community and Public Health Committee for Tuesday, March 15th at 2 o'clock.
Great. And I'll call roll. Commissioner Gerardo?
Here.
And Commissioner Chung?
Here.
All right, I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. All right, everyone. The next item is the approval of the February 15th minutes. And Commissioner Chow sent along this correction. I just want to note it before you all consider it. On item 3, the first page, the second to the last line, the word primate is there instead of primary. It should say, Commissioner Chow noted that primary care practitioners are caring for many TB cases. And so please, when you vote, note that that will be the version you'll vote on.
I move to approve the minutes with Commissioner Chow's amendment.
I second.
Thank you. And I'll just, I'm going to check the public comment line real quickly. There are people there. I think it's all staff. Folks on the line, if you'd like to make comment on the minutes, please press *3 now. *3. Okay, no comments, commissioners. And so I took your motion and second as a vote, and we can move on to the next item, which is a brief food insecurity update. And just for the members of the public and folks in attendance, we're tight on time today, so we're going to keep this item to a maximum of 15 minutes. Dr. Jones is going to update us on some data that was sent today.
Good afternoon, Commissioner Gerardo and Commissioner Chung. It's nice to see you, and thank you for requesting this information. So we pulled together information on the programs that we presented to you on December 21st, and I'll just go through them quickly and also answer any questions I've already received about them. The first item is it's a program called the Healthy Food Purchasing Supplement. As you can see, we have 3 different community partners for that. The first one is Eat SF, or Vouchers for Veggies. And this program serves about 1,800 pregnant WIC clients and about 1,000 additional families. There is right now 9,000 families on the wait list. About 75% are families, and the other 25% is single adults and or couples. And yes, this wait list is due to a lack of funding. It would take for this program, each household gets around $40 a month for fruits and vegetables. And if we were to serve 12 months and clear that wait list, it would be around 5.5 million. But I do have to say that for one of the things that we've really been wanting to do is extend the amount of time we provide pregnant WIC clients with these vouchers. We right now provide them for 9 months, but we would like to extend that to 12 months. And also add about 1,000 postpartum clients, and that would be another about 1.2 million to be able to do that. With that, I think unless you have any questions about that particular one, I'll just go ahead and go through the rest of the data. The second Healthy Food Purchasing Supplement is really to the heart of the city farmers market. We match CalFresh transactions there, and a total an individual could get up to $30 a month on that. And the farmers market meets convenes twice a week. So there is at least 6,300 people each month that are getting this benefit, and those are unique clients. And I know the number has been increasing during the pandemic. This is a really critical program to keep that farmers market actually there. The next one is the Alemany Farmers Market. We also provide funds to match the CalFresh transactions. Some of them we're partial funder there. HSA also provides funds. And they have no way of deduplicating, so we know that it's serving about 15,600 individuals, but there could be duplication in that number. And then the next one is the Pantry at Home program, which Preeti Rani, our Director of Nutrition for Maternal, Child, and Adolescent Health, talked to you all about. That program is really important. It's providing groceries to about 1,500 clients of maternal, child, and adolescent health. We did get an update, even though it is scheduled to end. The food bank would like to continue to operating this program. It's just going to be dependent on funding from Human Service Agency and or private funders. So they are looking to see how they can continue. Now, the EDSF program, the MCH program with Frisco Fathers, providing them with EDSF vouchers, it's serving about 30 people, and there is no wait list, and they're going to continue that next year. Now, through the Office of Anti-Racism and Equity, led by Veronica Shepard, we have also supported the Feeding 5,000 event at the end of the year. It's serving over 6,000 households. It's a huge event with many partners. And at this point, there is no wait list for that one. It is, though, at the end of the year that happens. Now, the next one is for the food pharmacies, which are operating at 9 of our health network clinics and 7 of the non-DPH clinics. This is led by Jana Cordero and Aaron Franey, serving about 3,600 patients and their families. And at this point, there is no wait list. Now, the rest of the programs that we did share with you last December is around the Sugary drink distributor tax grants. Those are led by Dong Mei Tan and Christina Gutta from the CHEP branch. The first one is SOMCAN. That organization is serving, and there is duplication in this number, 1,750. And at this point, they don't have a wait list. I did just get that new update right before this meeting. The African American Faith-Based Coalition is serving around 1,620 households. This is unduplicated. These are unique households. There is not a wait list, but I have to say that group is looking for additional funds to continue to be able to do this work. So they are definitely in need. It's a lot of people they're serving every week and every month. And they have multiple funders, but they are looking for additional funds to continue this work. Now, Farming Hope is another great program that's funded through the Sugary drink distributor tax, and they're serving around 20,572. But this does include duplication, and they don't have a wait list. Bayview Hunters Point Community Advocates is serving 822, and this does include duplication, but they do not have a wait list. Community Well is serving about 25 families. That is not that unique family, so that's not duplicated. There is no wait list on that. Now, Bee Magic is serving 905 families, which does include duplication, and they have a wait list of 70 until they can hire program staff. And the last one, Sister Web, is serving 13 unique families, and they don't have a wait list. And with that, I'll take any questions you might have.
Commissioners, I'll check the public comment line first. Folks on the line, if you'd like to make comment on item 3, please press *3 now. *3. No public comments. And Commissioner Gerardo, looks like you've got your hand up.
Thank you. My question is, and thank you for answering my initial question about funding on the 9,000 folks. Are the 9,000 that are on the wait list, as well as the 1,800 WIC clients, are they also receiving, any other of the programs that are on the sheet?
I don't know the answer to that question, but given the programs that are on the sheet, I would say that most likely not. EDSF partners with community-based organizations and housing providers, and that's how the wait lists are generated, because their partners are holding wait lists for people trying to get on the program to receive the fruit and vegetable vouchers. So likely they may be accessing some other type of program, whether it's a pantry or whether it's a free meal program, but they may also not be. So we don't really know the answer to that question.
Okay, because that was, could we put them or send them to another community partner to be able to receive uh, the Eat SF vouchers for the veggies. That's versus being able to raise either 1.2 million or even the 5.5. Are they, qualified for any of the others?
No, at this point, they wouldn't be, because what we do when we fund or when EDSF receives funding, they determine their allocation plan, and there's only so many partners that they can actually serve with the funds they have available. So generally, a wait list is because an organization hasn't been able to get vouchers because they've just maxed out what their available funding.
Okay.
We do always, I mean, they do always, and I'm sure a lot of the social workers and the, case managers have other, a list of other resources in the community, but often those lists are really pretty static, and they may not serve the needs of someone who, isn't able to travel wherever that resource
Right.
is available. So
Okay, so let's say for the 1,800 pregnant WIC clients, this is their only voucher, is the Eat SF for Veggie voucher.
well, they get WIC, but we know that WIC benefits are not enough, right, for the whole
Right. No,
household.
I know that. Yeah.
So yes, they're getting the WIC, they're getting an additional $40 a month in fruit and vegetable vouchers because of the partnership and our priority for them. So that's all the thing that they're getting from us, that, yes.
Okay. So they wouldn't be going to the Alemany Farmers Market with anything.
Well, we can't say that if they are qualified for CalFresh and they want to shop at Alemany, they may be going to Alemany
Okay, so it's
also.
possible that they would qualify for both?
If they would have to be under 130% of poverty to qualify for
Yeah.
both. Yeah. So there may
Okay.
be some who do qualify and then choose to sign up for CalFresh. And
Okay.
then they'd have to choose to shop at those markets on top of it.
Okay, yeah, that's where I was just trying to see what else could be done. That's all,
Yeah,
and-
there's definitely a need for either more income for families that are, right now we have inflation of food cost over, 12, 13% locally. So the money just doesn't go as far, and many people have not. The food bank did a survey and found that 81% of the people that are coming to their programs have not recovered financially from the pandemic.
Okay. Thank you very much. And I really appreciate you coming back with the numbers for us to further understand the challenges. Because my concern with the food costs, um, everything is so, like you said, substantially higher that it's going to be that much more challenging for families.
It absolutely is. And thank you for, requesting more information. And we're here to provide you any more information or talk through with you any of these things at any time.
Okay. Thank you so much.
Thank you, Dr. Jones, and the whole team that worked with you on this. Commissioner Gerardo, I'm going to move to the next item. Is that okay? Great. Item 4 is the COVID-19 impact on perinatal mental health in San Francisco. And I believe, Jody, that you're going to be sharing your screen. Stuckey.
Can you hear me now?
Yes,
Okay. I'll try to.
and I see it now.
Okay.
Maybe while Jody gets ready, I'll just introduce our two speakers today. Would that be okay, Mark?
Sure, we're tight on time, so please make it brief, Dr.
Yeah,
Hammond.
make it really brief. Commissioners, I believe you've met Elaine Armstrong, who's the Director of Maternal, Child, and Adolescent Health. And then I'm also happy to introduce you to our Senior Epidemiologist in MCAH, Jody Stuckey, who will be presenting to you today. Jody, it was hard to hear you, so I don't know if you want to test out your sound.
I hope you can hear me now. I'm holding the phone closer.
Yep.
Is that better?
That's much better. Thank you.
Okay, great. I'm going to start the presentation. Good afternoon, commissioners. Thank you for this opportunity to present. I am Elaine Armstrong, Director of Maternal, Child, and Adolescent Health Section. The presentation today will include data prepared by Hannah Hetch, a UC Berkeley Masters of Public Health candidate, funded to intern with MCH by the Cal-Maine Overdose Fellowship, and Dr. Jody Stuckey, MCH Senior Epidemiologist. Next slide, please. I'll start the presentation by reviewing San Francisco Health Network programs that screen, refer, or treat for perinatal depression. Then Jody will describe local data on perinatal mental health before and during the pandemic. I will follow up with a description of initiatives that are in process to address perinatal mental health. Next slide, please. MCH is part of the DPH and the San Francisco Health Network. MCH programs are connected to prenatal clinics all across our section in San Francisco, as well as Zuckerberg General Hospital. Next slide. Of the 19 MCH programs, almost half provide depression screening and referral for pregnant and postpartum people. Depression screening is a standard protocol for MCH public health nursing. Public health nurses screen for depression and/or anxiety at least once during pregnancy and at least twice postpartum. They use the Edinburgh Patient Health Questionnaire or General Anxiety Disorder Scales. Screening for depression in pregnancy and postpartum is done less consistently in our prenatal clinics, and which I'll discuss when we get to our San Francisco Health Network on postpartum depression. Okay, next slide. The COVID pandemic impacted MCH services. All MCH PHNs were activated at some point during the pandemic. All Black African American PHN positions became vacant during the pandemic, and MCH programs were operating with only partial staff for over a year and a half. Public health nurses carried increased caseloads when they were not activated. The waitlist for MCH PHN services increased dramatically during the pandemic. Public health nurses face new challenges in building trust and rapport with their clients because of the social distancing requirements and increased fear of home visits. When the pandemic started, there was no existing protocol for telehealth across our outpatient services. All visits were face-to-face, and the pandemic required us to get permission from the state to offer telehealth services. Next slide. I will share a case study about a postpartum death that happened during the pandemic to give you an example of COVID's impact. One of our primary care patients, a young African American woman who had a history of trauma, mental health illness, and had a preterm birth and developed severe postpartum depression. The client's primary care provider looked for programs to assist this client, but was told the programs had a wait list. Gaps in the staffing for case management at MCH and in other areas of the network made it harder for the client to access financial and housing resources. This client and her family had a long-standing relationship with her primary care provider at one of our health network clinics. And the doctor and the clinic were the source of most of, if not all, of her psychosocial support. Unfortunately and tragically, our client killed herself. This young woman's death was terrible tragedy for her family, the community, and healthcare providers who knew her and tried to provide everything that they could to care for her. To put this young woman's experience in context, Jody will now describe the local data on perinatal mental health. Next slide. Jody?
Hello?
Yes, Jody, you're on.
Can you hear me?
Yes.
Okay, I'll start again on this slide. Right, well, thank you for this opportunity to present, and thanks also to Hannah Hecht for helping prepare the data we are sharing today. Before the pandemic, according to the Maternal and Infant Health Assessment Survey, the MIHA survey, about 10% of birthing people in the Bay Area self-reported prenatal or postpartum depression. Black or African American birthing people were significantly more likely to report prenatal depression than white birthing people. Data from the MIHA survey also tell us that before the pandemic, perinatal depression was associated with lower family income, which in turn is associated with multiple social determinants of health, including housing insecurity, food insecurity, job insecurity, and limited social support. Switching data sources now to hospitalization records, we see that during the pandemic, consistent with what we might expect given the added stress from the pandemic, San Francisco hospitals reported an increase in depression hospitalization for pregnant people. This increase was statistically significant in 2020 compared to 2018, 2019 at the citywide level. When we look by race, ethnicity, and hospital, however, the data show that the increase in hospitalization was not evenly distributed. The citywide increase was driven by a statistically significant increase in depression hospitalization for white pregnant people at one facility, California Pacific Medical Center. Notably, depression hospitalizations for Black or African American birthing people decreased at UCSF, Kaiser, and Zuckerberg San Francisco General Hospital. Stratifying the citywide depression hospitalization trends by race ethnicity, we see a decrease in depression hospitalization for Black or African American pregnant people from 2019 to 2020. This decrease, shown on this slide flagged by the orange star, differed significantly from the changes seen during that period for all other race ethnic groups. It's difficult to draw conclusions about why we saw this disparity, especially because the prevalence of depression for Black African American people that we saw a minute ago in the MIHA survey. Available data do not suggest that this decrease in hospitalization was a good thing. The decrease in hospitalization for Black or African American women and the increase in hospitalization for white women widen local mental health disparities. Available data are not consistent with Black or African American women not needing services for depression. If we look at attempted suicides that result in emergency room visits for self-harm for Black or African American women of reproductive age, we see that while there was a decrease of 59 depression hospitalizations between 2019 and 2020, there was an increase in ER visits for self-harm of about the same magnitude. Self-harm ER visits increased by 50 visits from 167 to 217 ER visits. The disparity in self-harm for Black or African American women increased by 22% in 1 year. So I ask you to hold the number 59 in mind as we look at data on depression referrals in a few moments. But first, to reiterate, the data are not consistent with Black or African American people needing less support for depression. Data from the San Francisco Health Network clinics do not signal a decrease in postpartum depression for Black or African American birthing people between 2019 and 2020. The rate of postpartum depression among Black identifying mothers 6% in 2019 and 8% in 2020. That being said, our clinics are not screening all postpartum women consistently with the Edinburgh screening tool, which is the best evidence-based tool we have to screen for postpartum depression. This slide shows the total number of pregnant clients referred for mental health support by two MCH public health nursing programs, Nurse Family Partnership and Field Public Health Nursing. During the pandemic in 2020 and 2021, these programs referred 10 to 20 fewer pregnant people for mental health support. If you remember that number 59 from a few slides back, this decrease in referrals of 10 to 20 represents about 1/3 of the total citywide decrease in hospital admissions for depression for Black or African American birthing people. The fact that referrals dropped in 2019 and 2020 to the level seen in 2018 when these programs were understaffed is consistent with gaps in staffing making a difference. I will now turn the floor back over to Aileen.
Thank you, Jody. So now we have described COVID impact on staffing. MCH is fixing these gaps. In 2021, we hired one mental health specialist to screen all Black infant health clients. Clients are referred to community CBOs for therapy. They also get case management from social workers. We also hired a program coordinator and a liaison to manage the wait list. We have hired and will be training 3 new public health nurses to replace the 3 vacancies. We are committed to working down our wait list with a goal of no wait for clients who are referred for our services. We are also in the process of building behavioral health clinician staff into our clinical model, prioritizing those which predominantly serve Black African American families. We will hire 2 culturally concordant licensed social workers to provide therapy and wraparound services for MCH home visitor programs and the Black Infant Health, with funding from Mental Health Services Act. MCH is also working to support partners. We are developing a request for proposals to improve Black maternal health that would fund CBOs to hire Black mental health therapists with the Mega Black Funds, which is a mayor initiative. We also are going live on Epic soon, which will help with care coordination and communication between care providers in different agencies. We are also excited about the Mayor's Children and Family Recovery Task Force recommendation to develop or adapt a care coordination platform for this population to access care services across our city agencies. And we will be meeting with the task force to share early exploration and a vision for this new resource. We're hoping that the San Francisco Health Network leadership and city leaders will be able to advocate for this effort, given that many of our new initiatives are new. Sorry about that. And we don't have a good number of yet reporting these number of people served. Next slide. In closing, the pandemic increased our perinatal mental health need and widened our local disparities. Support is especially needed for Black or African American prenatal people. MCH is prioritizing staffing gaps to address the shortage of our Black therapists and programs wait lists and strengthen communication and collaboration. These past few years have been very challenging, but members of our team continue to persevere, and we are committed to serving the community. So I thank you once again for this opportunity, and we look forward to answering any questions.
Thank you very much. I'm going to quickly go to the public comment line to make sure that anyone who's on there has a chance to comment before we go to commissioner questions. Folks on the line, if you'd like to make comment on item 4, please press *3 so we can recognize you. *3. All right, no public comment, but I do see Commissioner Dorado.
Okay, thank you very much for this excellent presentation. And I also want to say a special thank you to Hannah Hecht, who is our Kalmanowitz intern that is part of a grant from the Child Development Center and from UC Berkeley. And it's great to have your information and all your hard work being able to be presented, Hannah. So I also wanted to call you out to say thank you, since I appreciate it. My question particularly, I mean, I think you've answered most of my previous questions that I had submitted, and I really appreciate it. On the last slide, with the initiatives to address the mental health system gaps, when on the wider DPH and community partner efforts, I know you had mentioned you don't have any numbers on how many clients are being served by any of these programs, correct?
Yeah, correct.
So with, for example, Team Lily and Solid Start, both at ZSFG, I always can't get those acronyms right. What is there a seamless kind of moving and support for the families that start in Team Lily that go then? Are they then followed up by Solid Start? Because I've had mixed messages from the community. So I guess I'm just, asking for what your thoughts are, because one of the things is we're all, trying to focus, especially, well, in all of our communities, that we don't have these silos, that, these families are able to be supported and not have to really search out whether or not they're in Team Lily to go to Solid Start, or with Rams, with Embrace. That's where I guess my concern is in in the in the programs and helping the families transition and not be in silos and have to start everything all over again and fill out more forms or whatever else it might be. So I don't know if just asking what your thoughts are.
Yes, I can. So that's one of our weakness in our network. It's a broken system that we need to fix to have better care coordination for our clients. We know that they may be accessing one service, but it's not being communicated to their providers, or the providers don't know what the other networks or CBOs are doing. So that's one of our really, really strong task force, is to be able to close that gap and bring this initiative to this mayor's children initiative, family recovery, on how we can really resolve that. But that is definitely a weakness within our system. We don't know what each others are doing. And if Dr. Holly Hammer want to say more to that, please go ahead.
Sure, I can just pitch in just to reiterate what Elaine just said, Commissioner Gerardo. One of the things we really hope to take from this recent work that we have just reported on, of a lot of different programs that have been set up recently, or are longstanding programs just pivoting in terms of their scope to address the really the whole person, the whole family needs. One of the things that we are fully aware of is the need to coordinate among programs and have reliable referral systems, and make sure that, as Elaine mentioned, this new care coordination system, which we hope to really to grow, to pursue, would be an easy way of seeing who is involved in the care of the family. But for right now, I think there's some low-hanging fruit. I think for women who are being seen in high-risk OB, who are part of Solid Start, that there is, they sort of act as that glue to connect with the other providers on the care team. But that's really primarily for pregnant and birthing people who are getting their care at ZSFG. And as we've seen in this presentation, there's a lot of need out in our community-based services. There's a lot of need, I think, on the streets and in other areas of the city where we may not be finding the pregnant people and birthing people who really need these services. So so much more to do, I think, in terms of outreach and then coordination of care once we get people into care. So everybody knows who's doing what, and we both avoid gaps in care as well as redundancies, which neither of which is good for our clients.
Okay. Within the mayor's initiative, is there money to be able to kind of focus on someone being able to do such coordination to try to have a hub? I mean, someone just sent me some information on a pre-postpartum group called Natural Resources on Valencia Street, for example. It's like, oh, I've never heard of them. In here, I've got a NICU clinic, but all I'm saying is there is there funding to be able to have like a clearinghouse or a central something to for this, or am not?
My understanding right now, and I'll ask Dr. Baba, who's on and has been one of the DPH representatives in the Mayor's Children and Family Recovery Task Force, to help fill in the blanks that I'll leave. But my understanding is that the recommendations have now been, are sort of now in departments, parsed out to departments, and for us to figure out those initiatives that we will own in terms of carrying them forward, that we are putting together budgets for what it would entail to bring those recommendations to fruition. So that's where it is right now. So Navina, anything that we should add on that?
No, that's exactly right, Hallie. So that the task force that was convened made recommendations around multiple different dimensions, and then it was adopted, and it's kind of on the department and the city to decide how to move forward with those.
But that would require, I mean, was Dr. Baba funding connecting with this versus DPH just, figuring out how to do this without funding?
Yeah, it wasn't, there was no funding attached with it. It was, if it was going to be put into the budget, whether this year or next year.
Okay. No, I appreciate it. It's just a little frustrating that everybody's going to need to do more work without any funding necessarily behind it. But thank you very much. And, we look forward to possibly, I'd really like to have maybe an update to our committee, if it would be possible, in what you feel, a timeline would be possible, just for an update in maybe 9 months, 12 months, because I think, at least for what our committee is doing, this is really high priority, like we had seen the food program being a high priority of needs. So I would, welcome your feedback on when would be a good time for us to be able to revisit your progress, since hopefully you'll have more staff to be able to do that.
And possibly while they're thinking that, Commissioner Gerardo, Commissioner Chung has her hand up, so it's okay if we go to her as well and
Please.
maybe thinking. But and I always can work with these folks around the cadence of
Okay.
when to come back. Commissioner Chung.
Thank you so much. And I share all the concern that Commissioner Gerardo had mentioned. This, these kind of challenges. I was wondering, if it is unique to San Francisco, or are we seeing the same trends nationwide? Because in terms of funding, it's not always about general fund coming in to fill the gaps of where all these fundings are, and and hopefully, there are champions in the state level and also in the federal level, to help look at, identifying resources to help bridge this gap. And the other piece that I am curious, because I was looking at the type of services that the different programs offer. Some of them offer case management service, but not necessarily to the birthing person, but to the children. So is there, like any plan on, like looking at how to maybe, like engage in some of these high needs clients to intensive case management services? I'm saying that only because, I came from the HIV world, and we see how intensive case management really make a difference in, engaging people in care. So, and my questions comes from, the same kind of understanding.
Yes, I can speak to that. I totally agree with you. Intensive case management is very important. Even one of the recommendations from our Solid Start colleagues were recommending like navigators. Navigators are, someone that can, like really support clients who are, have severe, challenges or trauma, and they can't be able to take on a task like really maybe if they have to get their medication or they need to see their providers. A navigator can help support clients with their day-to-day functions and following up through with, whatever their needs are, helping them access housing and food, and address their food insecurity, and helping them with, if they need they have a newborn baby, just really connecting them to the resources that are available. So that's something that we're looking at, possibly how we can work with navigators and bringing on these mental health therapists and working with our behavioral health clinicians. All of those wraparound services will be crucial and key, but we definitely have to have a way to communicate with one another. And that's through that care coordination.
Yeah, I know I'm preaching to the choir for sure. And yeah, and so I think that, the other concern is, there's a drop in accessing of these services. So it's really that I think is a even bigger concern is if they don't ask for help, then there's no way for you to offer any to them. So yeah, so thank you for doing this hard work. And, my heart breaks when you share that, that tragic stories.
Yes.
Commissioner Chung, I'll just add to our answer in terms of the national trends. The CDC noted that for 2016, 2018, there was a national increase in self-harm visits to the ER for young women. And they noted that it co-occurred with missed opportunities for screening. And preparing this presentation, I did check, and we have the same pattern for that period, 2016 to 2018 in San Francisco.
Thank you for sharing that. 2016. That's
Right,
a pretty remarkable year.
Thank you, presenters. Commissioners, any other questions or comments? And Ms. Armstrong and Dr. Baba and Dr. Hammer, I'll check in with y'all in the next week about scheduling a update, and figuring out what's best for. But thank you so much for all the work that went into the presentation and then the verbal presentation today. The commissioners were obviously really taken aback by the data and what you had to say. Moving on to item 5, whole person integrated care update. And I need to share my screen. Give me 1 second.
Thank you, everyone. My name is Dara Capo. Let me open my camera here. Thank you to my colleagues who presented before. Really acknowledge and appreciate the work that you do and its importance. Here to talk about whole person integrated care. My name is Dara Papo. I'm the director of the section. If we can go to the next slide, please. Whole person integrated care is a relatively newly formed section of ambulatory care, which brings together non-traditional primary care, urgent care, and behavioral health clinical services, primarily serving people experiencing homelessness. We take a data-driven, collaborative approach to caring for our highest risk patients and facilitating citywide care coordination. Can move to the next slide, please. Oftentimes when we meet individuals in the health network's homeless system of care, whole person integrated care connects with them when they're at the urgent or emergent phase, which is where the person is starting on the journey in the red box. And through collaborations and services, our goal is to work with people on their journey to recovery and wellness. If we can go to the next slide, please. This is the organizational chart. I have the honor of reporting to Dr. Hallie Hammer, the Director of Ambulatory Care. We have two medical directors, Dr. Barry Zevin, who is on this call as well, who oversees urgent care, open access, SORT, shelter health, and street medicine, Kalim. We'll talk about these slides a little bit more on the next slides. And Dr. Devorah Keller oversees medical respite, alcohol sobering, managed alcohol, and healthcare and SIPs and supportive housing. These programs are all run by an incredible, committed, and knowledgeable group of nurse managers, Les McTire, Kate Schuton, Jamie Moore, and Alice Magamian. And our data and population health section is supported by Spencer Williams. If we can go to the next slide, please. So about a year and a half ago or so, when whole person integrated care was formed, these were the programs that it consisted of, programs that had previously sat under primary care or behavioral health. There's street medicine, alcohol sobering, the whole person care Medi-Cal waiver that ended in 2021, shelter health, our open access clinic, which is our 4 walls clinic for street medicine patients located at urgent care. It's formerly known as Talmadel Urgent Care, now referred to as WPIC Urgent Care, still located at 50 Ivy. We have healthcare services and supportive housing and our medical respite clinic. If we can go to our next slide, please. So this is data from calendar year 2020 and calendar year 2021. Our numbers increased, which we are thrilled that we've been seeing more patients in 2021. And just to sort of ground that there's about, of the 7,500 patients that we saw in 2021, the point in time count for 2019, which identified individuals experiencing homelessness in any given night in San Francisco, is estimated to be about 8,000, of which about 3,000 were chronically homeless. In any given year, it's estimated that 16,000 to 18,000 individuals will experience at least one night of homelessness. And we are really proud that we're really connecting with a large number of individuals, particularly those experiencing chronic homelessness and dealing with medical vulnerabilities. Often, in looking at these numbers, a number of individuals will connect with more than one program. And so while these are the summary per program, individuals do crossover programs, and we really pride ourselves on having connections across our system of care. In looking at some of the changes, also just to say, this is information that's pulled from our electronic health record, which is EPIC, and does not include programs from managed alcohol or a mobile vaccine. In looking at some of the changes between 2020 and 2021, the numbers for medical respite shifted as due to COVID, there was less outflow and ability for people to go back into the community for medical respite. So in 2020, people were staying longer. Our numbers for sobering dropped because more people had shelter-in-place sites available to them or were connected with our managed alcohol program. Our numbers from shelter health and street medicine decreased largely because the shelter-in-place work was being supported by a large number of disaster service workers, and the documentation occurred either under shelter health or street medicine. As the workforce shifted from disaster service workers to either our core existing staff or temporary hires, we saw a reduction in those numbers. There also has been a wind down of the shelter-in-place sites. A true increase in service has been within our urgent care clinic. There has been a 29% increase in services in the past year, largely due to, I think folks needing care sometimes when their primary care clinics may not have been accessible to them. And also we've made a lot of connections with individuals who were staying in shelter-in-place sites. And we're also now providing healthcare to individuals associated with the Tenderloin Initiative and the Tenderloin Lincoln Facility. A large number of individuals, so about 7,500 individuals seen for over 47,000 encounters in 2021. If we could go to the next slide, please. This talks about our budget. This is for fiscal year 2020 to 2021, our total budget being about $13.6 million, the bulk of it being due to salaries. If we look at the total income, the work order from HSH funds a lot of our street medicine and shelter health work. We are primarily general fund supported and are working now that all of our programs are in Epic to make sure that we are not missing any billing opportunities, and are also working on increasing the field-based ability to use an iPad for service documentation to help our increase billable services for a lot of the work that happens when staff are in the field. If we can move to the next slide, please. So we really exist in a continuum, and our partners include our sister departments of the Department of Homelessness and Supportive Housing, a number of different sections of the DPH, behavioral health, primary care, maternal child health, and a number of different sort of safety net resources, including the hospitals, the community paramedics, and some of our sort of special initiatives, the COVID infrastructure, and the Tenderloin Initiative. So we really look at part of the system of care serving people experiencing homelessness across San Francisco. We can move to the next slide, please. A lot of growth I'm excited to talk with you about. So in looking at COVID healthcare services for people experiencing homelessness, we've been providing services in the shelter-in-place hotels, serving individuals not connected to care. Clinics range from a half day a week to 3 to 4 days a week. There's a lot of work happening as DSWs have gone back to their home departments. Our staff have continued to support the shelter-in-place sites and are working with guests as they are transitioning either back into the community and or to permanent supportive housing. We have a mobile vaccine team that has been going to shelters, shelter-in-place sites, supporting people who are unsheltered, who are not fully vaccinated. Into the next slide, please. So these are some pictures of our staff at Site F in the Bayview with their trailers, and staff really do use a golf cart to get around and to help people get from their trailers to the clinic. We have a picture of one of our nurses who was hired on with us as a temporary COVID hired nurse and is now moving into a permanent position. And on the bottom, we have a nurse working at one of our shelter-in-place sites. As these sites got set up, we really have been sort of piecing together infrastructure, and this person for at least a while was using an ironing board as a desk. So just sort of showing the creativity and ingenuity that goes into community-based work every day. Going on to the next slide, please. We have our street overdose response team, which is funded by PropC, or City or Home. The target population is individuals who have recently survived an overdose. This is a program run along with the San Francisco Fire Department's community paramedic. There is a community paramedic and a peer that responds to 911 calls of somebody who might have had an overdose. They will offer resources, connections to services, and we know that that may be a window of opportunity, but oftentimes later, that's not the time that people are most engaged in talking about change or other resources. And so we have our post-overdose engagement team, which is DPH staff and community-based organization, who within 72 hours will outreach the individual and provide ongoing engagement and connections to services and care. SORT has responded to over 560 individuals who experienced an overdose in the first 6 months. Over half were unsheltered. And of the demographics, 50% were white, 24% Black African American, and 12% Latinx. our goal is really to bring services to the community and where individuals are. If you can go to the next slide, please. We are in the process of hiring up some additional staff, but on the bottom, we have some of our SORT team members, waving to Dr. Barry Zevin. And on the top, we have our staff who work on overdose prevention, which is really all of our staff. This was a recent training of our street medicine, shelter health, and urgent care staff. We really look at overdose prevention as being core to all of our work. In fact, whole person integrated care has seen in the past year 300 patients for either buprenorphine starts or refills. And so in addition to SORT, this is really one of our core goals and missions. Next slide, please. Our managed alcohol program is one of our newest and in some ways, one of our most exciting programs. It started because of COVID, when individuals were unable to safely isolate in their rooms due to their severe alcohol use disorder. And we have really found a lot of connections between our high users of sobering who have been participating in managed alcohol. It provides a nurse-supported residential setting focusing on decreasing life-threatening withdrawal seizures, emergency service utilization, and binge drinking behaviors. In the first 18 months, MAP served 23 clients for a total of 28 admissions. Like any sort of treatment modality, we know that people are going to cycle through, and there's a big flow between sobering and managed alcohol and back. During that first 18 months, we have detailed that MAP has diverted over 589 emergency services calls, which saved the system over $1.3 million if you calculate emergency services, emergency service calls, emergency department visits, and inpatient hospitalizations. MAP is currently 10 beds, funded by our City Our Home, Prop C. We're working on locating a permanent location. It's currently functioning out of a shelter-in-place site, and we'll be scaling to 20 beds, 10 focusing on Latinx and Indigenous Mayan communities. And if we can go to the next slide, please. Again, given this being a shelter-in-place site, we have our MAP staff working in the offices that used to be a hotel room. And then we have a thank you letter from a MAP participant. And I just want to let you know that 2 years ago, this individual first arrived at sobering. They were brought in by the community paramedics. When we look back at their note that was written in Epic, they were screaming, they were cussing. It took them a while to be redirected. They finally calmed down. And a couple minutes later, the individual pulled out a package of raw meat, which they started to eat. The community paramedics were called again. They came out. 10 minutes later, the person started vomiting. Were determined not to be able to sort of safely be retained at sobering, and were transported to Zuckerberg for evaluation and possible psychiatric hold. This person had then been a frequent user of sobering, has been through MAP a couple of times, has greatly decreased their alcohol use, and this week has moved into permanent supportive housing. And so I think when we look at the fact that people's journeys are not always linear, I think it's also really important to really ground in just how resilient individuals can be, and the ways that a committed and dedicated staff to follow people as they come and go from the program really can lead to solid outcomes. The MAP staff will keep in contact with them and with their healthcare providers as they transition into supportive housing. Next slide, please. We have our CalAIM Enhanced Care Management and Community Supports. CalAIM is the codification of whole person care, funding services not previously funded by Medi-Cal. It continues our work of data sharing and data integration. CalAIM is in sort of two sections. There's enhanced care management, which provide care coordination by a multidisciplinary team. Referrals come from the managed care plans. Our street medicine team is one of the DPH's ECM providers, and also community supports, which is another program that the managed care funds can choose to provide under CalAIM. And medical respite and our enhanced care management services started in January 2022. Sobering will become a community support in July. Of our street medicine ECM team, we've had 30 members assigned to us. We have engaged 20 and we are outreaching 10. We are regularly meeting with the managed care plans, and by regularly, I mean weekly. It's bringing on non-traditional providers into Medi-Cal is taking a lot of coordination, both internally and with them, and we're working closely together to help make this successful. Next slide, please. We have an all-love clinic, which works out of urgent care. It targets we are serving individuals who are women, transgender, non-binary, their partners, pregnant people experiencing homelessness, and those who are postpartum. About 70% of people experiencing homelessness are cisgendered men, but we know that other populations have disproportionate burdens of syndemic issues, HIV, sexually transmitted infections, and poor pregnancy outcomes. We partner with a number of community providers working with pregnant and postpartum individuals and are expanding our outreach to other programs. An example of that was one of our staff had met a young woman at the Tenderloin Linkage Center who was interested in coming to All Love. She felt like this would be a safe place to talk to a medical provider. The staff person, the health worker, arranged to meet this woman on a corner in the community this morning. And as I was coming to work this morning, I saw the health worker escorting her and making a warm handoff to the staff at the All Love Clinic. And so we really do look at this as part of our system of care. We see about 10 patients for our half-day clinic at this point. Next slide, please. We have our Permanent Housing Advanced Clinical Services team, which we call the FACS team, also funded by Prop C, and we'll have an ECM CalAIM team as well. This is serving the over 8,000 individuals in permanent supportive housing who don't have health services located in their building. Because there are a number of people that don't have healthcare services, we're really focusing on consultation and capacity building for the community-based organizations that provide on-site services. We will have a staff that are available to be able to come on site that will follow people either short-term or ongoing. We are currently doing a pilot of 10 sites. The pilot's going to last probably about 3 or 4 months. And we're learning what the biggest needs are for both the CBOs staff and the tenants in supportive housing, with a goal to identify which are things that we can include in our capacity building, coaching, and training, such as challenges with insurance and benefits, and which are things that we really would want to make sure to provide on-site care, such as medication for substance use disorders, and or things like wound care. So we're probably in like month 1 of this pilot. We are also, thank you, next slide, please. We're also in the process of moving. Our 50 IV clinic, the Whole Person Integrated Care Urgent Care Clinic, is being renamed the Maria X. Martinez Health Resource Center, which is incredibly moving to see the work of Maria X honored in this way. And so the clinic is moving. We are expanding things like our dental and podiatry services, working with the Office of Care Coordination to integrate behavioral health. And the clinic will remain open Monday through Saturday, continue to serve individuals from the Tenderloin Linkage Center and street outreach. We will have a new home probably around August 2022. So we're in the process of preparing to prepare to move, and what that will mean to have sort of an integrated services model at that site. So looking at what's next in 2022 for whole person integrated care, looking for our new home for sobering and managed alcohol, active conversations are occurring. with the possibility of adding site-based isolation and quarantine for people experiencing homelessness needing on-site recuperative care. We're working closely with behavioral health and mental health SF to ensure coordination and integration of services for people experiencing homelessness, integrating with population health and disease control activities, working on right-sizing our staffing to match program growth and building our internal infrastructure. And our key clinical focus areas are our syndemic response, palliative care for people experiencing homelessness, and low barrier in care and treatment for substance use challenges. I've been in this role for about a year and a half. It's an honor and a privilege to support the incredible work of the whole person integrated care staff. And I greatly appreciate the support and leadership of the Commission and of the DPH in creating and nurturing these services that support our most vulnerable residents. Thank you for having me today. Please let me know if there are any questions.
Commissioners, before we go to you, I'm going to check the public comment line real quickly. Folks on the line, if you'd like to make a comment, this is item 5. Please press *3 to raise your hand so we can recognize you. *3. Okay, no public comment, commissioners. I see Commissioner Chung's hand.
Thank you, Mark, and thank you, Dr. Popo, for the this wonderful presentations. Well, Dr. Seven can tell you, it brings back a lot of memories for me. Like, it's great to see, and it's really inspiring to see, like that, like the program had, the whole person care program had evolved into the current structure, because I think that that's a lot of lessons learned, and especially I'm really heartened to hear about palliative care for homeless. Like that, like that means a lot. To know that like those who are unhoused will have a place that they can pass on with dignity. This is just out of curiosity. It also sounded like the whole person care program actually overlap with some of the other projects that we've just heard about, like the perinatal mental health, for instance, and I wonder, like if there's opportunities, to look at different ways for different projects to collaborate even more, because you're all doing such excellent work, and I think that if there's a way for collaborations, you'll be untouchable.
Thank you. No, that's a great point. And through projects such as Team Lily, I think we are really working together to sort of identify what the Venn diagram is of our shared populations, both with maternal child health and with behavioral health. This is where I think, it is the question of both like the provider collaboration and the population health data to sort of know who we're working with and then how we can work together. So that's a very important point. Thank you.
All right, and Commissioner Gerardo.
Thank you, and thank you so much for this excellent presentation and hope, put it that way, in going forward. Do you have current numbers of families or people served at the Maria X. Martinez Health Resource Center?
Great question. So the center will be opening. Right now, it is still located, our clinic at 50 Ivy, and we do
Right.
see about 50 patients a day on average.
Okay. I know in most of the programs that you presented, so for example, in the All Love program, you said about 10 patients a day, or 10 patients for a half day. Are you in all of the programs, let's say with also the pilot on the program that you presented, the PHMCS was?
Program, yes.
Yes. There's too many initials. Could you remind me again, in that pilot, how many have been served?
So we're serving 10 sites. A lot of the work has been more information gathering.
Okay.
I think we are anticipating that team will serve. Our sort of initial assumptions is that that team will have about like 2,000 calls or queries a year. About 1,200 individuals will receive a sort of a short-term intervention, either coaching or on site, and that there will be about 600 individuals that receive ongoing care. We're waiting, I think, until we sort of launch across all of the sites to start to build caseloads, so that we can make sure that we really identify the right referral criteria of who makes sense for us to serve and who should we really be working to connect them back to community resources that they have available that maybe aren't connected to.
So within that, since I'm also, reading some of the data from the Tenderloin Linkage Center, so with the number of referrals made, which is high, but then those that actually linked is really low.
Yep.
So that's where I'm also wondering within this program, are we going to be able, is it within the project, within this, to have that data and as well, not that I care so much about data, but how many people, are actually y- out of, 500 referrals, how many actually received the referrals just because
Yep.
resources are difficult. And like, what's the end product line and how many were able to receive the services? Are we going to, that's what I think is important.
Yeah. It's a hugely important question. When it's the health department staff making referrals, we will be able to know that through documentation in Epic. And so when it's referrals outside of our system, I think it's going to be harder to sort of collect that information. But assuming that a lot of the connections will be to maybe primary care clinics or other services within our sort of system of care, we would be able to track that information.
Okay, in moving forward, will you have like a mechanism or something, a reporting mechanism that it get back to you at all with disposition or, conclusion? I'm just wondering within the system whether
Yeah.
or not as you've got a pilot and you're moving out, if
Yeah.
something like that could be built into the system.
Yeah, the whole sort of closed loop referral
Yes.
is definitely the gold standard that I know there's a lot of interest in. I think because the work that's going to be done and supported, a lot of it will be done by the on-site housing providers that use their own sort of documentation systems. We haven't yet necessarily thought, how do we get information from other department funded agencies, Salesforce systems to sort of flow into Epic? Those are the conversations that when we look at the Office of Care Coordination, Mental Health SF, Cal AIM, that's really the work that keeps on happening. How do we get more information sort of into Epic from other systems so that when people are looking at, they have a patient in front of them, they can really know where do they have other care coordinators, where have they been seen? And I think that those conversations and planning are still happening, but you're exactly right on of where we want to and need to go.
Yeah, that's what I'm wondering what could be built in. So for example, with me, with any of the families that I see, I can go into Epic and look at
Yep.
like the care everywhere, if in fact.
Yep.
But there are certain like Mission Neighborhood Health, apparently to be part of that, it's very expensive. So they're not on that. So
Yep.
so that's where I didn't know if there was anything built in that could help this, put it that way.
Yeah, I mean, a lot of the work that went into whole person care was sort of data sharing, building out a section of EPIC for social determinants of health, finding ways to allow non-DPH staff when appropriate and legally appropriate to access
Right.
a subset of EPIC. And so that work is continuing. I think when we come back in 6 months to a year, let's check in about if this is solving some of these issues, and if not, what we need to do to sort of get there.
Okay, that's great. It's just, you know, we could, just to get, those technical people to be creative. That's all.
Yeah.
That's all I'm saying. And but I very much appreciate the presentation and the work
you.
going forward.
Thank you.
All right, any other questions or comments, commissioners? Thank you so much
Thank you.
for the presentation. And commissioners, we can move on to item 6, which is emerging issues. Anything? Folks on the line? Actually, there's nobody on the line. So I believe we can move on to public comment, item 7. This is a time that folks in the public can comment on something that's not on the agenda. I see one person on the line. If you'd like to make a comment about something that's not on the agenda, please do so now by pressing *3. I don't see any comments, and so now, commissioners, you're at a consideration for adjournment.
I move to adjourn the meeting.
I second it.
All right, so the meeting's adjourned. Thank you, everybody. Thanks for y'all that stayed around and for your amazing presentations, and of course your really impactful work. Take care, everybody. Commissioners, I'll see you soon.
Thank you.